All right, guys, welcome to the Digital Barbell Podcast. Thanks so much for joining us. If this is your first time finding our podcast, welcome. My name is Jonathan. This is my wife, Blakely. We're the owners and operators of Digital Barbell. We're currently living, working, and traveling full-time in our Airstream, which is why you're seeing the view that you see now if you're watching this on YouTube. Today's episode is going to be great for anybody who has ever dealt with back pain, pain from running, pain from biking. If you've ever wondered if maybe you should get an MRI because you're having pain, we're going to address that and a whole bunch of other things related to the mindset of getting in shape too. We actually have a guest for this episode. They're not sitting right here because one of the benefits of our reach growing over the years is that we have more eyeballs on our podcast and YouTube channel and all that stuff. But the downside of that is we've been doing this podcast for over 5 years now. We have almost 500 episodes. So all the new people that have found our podcast have missed a lot of awesome stuff. So sometimes we like to go into the archive, bring back something that we think would give you a lot of value. And this episode is with Doctor of Physical Therapy and Strength Coach Will Morris. Anybody who has spent any time in the starting strength world definitely knows who Will is. He's an Army veteran who is retired now and just doing a private practice with his physical therapy. And there's tons of value in this episode, which is why we're bringing it back. Anything else you want to throw in before we get into the interview?
I don't think so.
Well, too bad, because I just thought of something else.
Yes, let's go.
I wanted to let everybody know that Blakely wrote a 8-week beginner strength training program called Strength Made Simple. It's for people who are new to strength training, know they need to get stronger, or for people who have been out of the gym for a long time, used to be in shape, and are intimidated as to where to start, or people who are doing cardio only and know they want to add some resistance training in. I'm not really promoting that program today, but I want to tell you that we took a week of that 8-week program and we made it free, where you can try it out, because a lot of people are wondering, like, what's this going to be like?
I think there's some hesitation if you're just like, you hear things about a program and you're like, is it that
I wish I could
good?
try
like,
it.
Wish I could just see and feel what it looks like. That's exactly what we're giving you. So we're giving you the first week of the program absolutely free. And I know if you do the first week, you're going to be like, how can I get the rest?
And so our clients that do the program, they get it in our app. They see all their workouts in the app. They interact with us through the app. Obviously, we can't set up everybody who wants the free trial in the app. So we turn that 1 week into a PDF. You can still click on all the exercises and see video demos of Blakely or myself doing everything, but it's a great way to kind of dip your toe in the water and see what it's all about. So,
and just see like what it feels like to get workouts from Digital Barbell, because we have a different type of workout,
a different mojo
than you might get from other programs. So it'll give you a chance to just experience that.
So I'll put a QR code on the screen here on YouTube where you can scan it with your phone. It'll take you directly to where you can download it, or I'll put a link to it in the description if you're listening to this on audio. Okay, let's get into this interview with Dr. Will Morris. Will Morris is a DPT, an OCS, an OG SSC, and he's currently enlisted in the military where he serves as a physical therapist. He's helped hundreds, if not thousands, of people get stronger and come back from injuries, including myself. I've been working with Will for about 3 months now, helping me get over a shoulder injury and, help me fill out the sleeves of my shirt a little bit better too. So thanks for being here, Will.
Of course. Thanks for having me.
Well, first off, thank you for your service to our country. Where are you stationed now, and where have you served recently?
Well, the first thing I would say is whenever somebody says thank you for your service, I always say thank you for paying your taxes.
You're welcome.
Because it's always a weird thing whenever people say thank you for your service, because like I'm a volunteer and I get compensated fairly, so it's not like that. I haven't gotten a raw deal by working for the military. So I actually enlisted in 2002. So it was a few months after 9/11. I was in college at the time at Lubbock Christian University. And I remember on 9/11, every day we had our morning class and then we had chapel. So everybody had to go to the chapel on post, and we had like a community-wide or university-wide session where there's like praise and worship and stuff like that. And then that was their venue for getting information out to the student body. And we had these two big monitors up in the chapel. And whenever I got there that day, they had the news playing, and we saw the events of 9/11 play out. So I think right at that moment, I knew I was going to enlist. But my mom at the time, she's gone now, but she wanted to make sure that I had finished my degree. So I went to the recruiter a few days after 9/11 and talked to them. And then they told me what day I could actually enlist, because you can delay your entry into service a certain amount of time. And so I went and found out what the earliest day I could leave for basic training and still finish my degree. And so I did that. I left for basic training in July of 2003, just about a month and a half or so after I graduated from college.
Mm-hmm.
Originally, I was at Fort Benning. Then I went to Fort Bragg for some training, and then I left Fort Bragg, and then I kind of bounced around. I got picked up for officer candidate school in 2005. So at the time, there was a problem with officers getting out, because after a few years of war, officers were finding other opportunities outside of the military,
Mm-hmm.
especially their officers. So every major commander was allowed to select 10 people from their command to just go straight to officer candidate school. And I was one of the 10 that was selected from the Fort Benning command. Since then, I've been stationed in Alaska, San Antonio, Texas, Hawaii, California, Joint Base Lewis McChord in Washington, Korea, and now currently I'm at Carlisle Barracks in Pennsylvania.
And it's not like you're just like a solo dude. You got a family too.
Yeah, my wife has bounced around with me all around the Pacific for the last 15 years or so.
Man, I'm sure you got a ton of stories and seen a lot of things. I enjoyed following you on Instagram through your time in South Korea. That was kind of an interesting time for you, it felt like.
Oh, that was a really interesting time. That was some of the more memorable, but maybe not my most enjoyable 2 years in the military. But that was interesting. Yes.
I don't know if you know this, but you actually met Blakely and I briefly in 2017 in Wichita Falls. You were at the Starting Strength. What do they call it? A seminar convention? I don't know what they call it. Yeah.
No, I actually remember that. I remember that well. I remember both of you guys well.
We always stick out at like a sore thumb at those kinds of things because, like, you know, Blakely owned a CrossFit gym at the time. And like, as you look around the room, there aren't a whole lot of people that look like CrossFitters at a Starting Strength event. And I think Rip always picked on us for that reason.
No, but it's also one of the things that was memorable is that you were a husband and wife team. Yeah. And that's something that's kind of unique. You don't see that very often, but yeah, I remember you guys well.
Yeah. Those are always good times at that gym. What's a typical day like for you as a PT in the military?
It depends on where you're stationed. Like whenever I was in Hawaii, I had my first patient come into the clinic at 6:00 in the morning. And so I would usually get up about 3:45 or 4, get dressed. It was about a 45-minute commute to the hospital. I would see patients from 6 in the morning till about 3:00 in the afternoon. And then luckily the way that the clinic was set up, I could leave by about 1500 every day. But that's when everything in Hawaii shuts down at 1500 and everybody just goes and gets stuck in traffic. Here, my day is more, I get to the clinic at about 7:15, 7:20 every day. I see patients up till about 16:30. Finish up my notes and stuff like that. And then I'm usually heading out the door at 5:00.
I always have to do a little conversion in my head because a lot of time you reply to my comments in True Coach with military time.
Yeah. So
makes sense though. I'm with you.
So 5 p.m. and it's right now, this will be my last position in the military as long as everything goes according to plan. And this is almost 100% patient care. So instead of administering a department like I did in Korea or an interdisciplinary department like I did in Korea, this is all just 100% patient care. So It's just after patient after patient after patient until lunch, and then patient after patient until it's time to go home.
Pretty much all that time on your feet too, I imagine.
No, so I mean, I've got a sitting desk. I walk around a lot because I take a lot of my patients out to the exercise gym and work with them out there and stuff like that. But there's a fair amount of sitting and documenting. For some reason, like if you go to your primary care manager and they write a medical documentation for that encounter, you probably get about this much text. A physical therapy encounter has like this much text, and so
If you're
Every
just
time.
listening to this, he just the first one was like an inch long, and then the second one was like 3 feet long.
Yeah, the documentation for a physical therapy encounter is ridiculous, and it's not like you necessarily have to do all of that stuff. But we have monthly peer review, so we have to take a random sampling of our documentation from that month, and another physical therapist that is of equal qualification gets assigned to pull random selections from your stuff. And as this happens, somebody gets a good idea. Well, we need to make sure that we're documenting this, and we're documenting this, and we're documenting this. So now I've got a 50-minute appointment, and 40 minutes of it is just making sure that I hit everything on peer review, and then actually doing 10 minutes of stuff of actually trying to diagnose.
It's not all TheraBands and 5-pound weights. It's like a lot of computer work and using your brain also.
Yeah, it's a lot of like making sure that you're documenting everything that the patient is telling you, and then using your note to kind of tell a story, so that if another provider takes on that case, they could refer back to your note and basically see your thought process as you went through the evaluation. So there's a good reason why it's lengthy. Yeah. It's just sometimes it gets to the point where you spend 90% of your time documenting and only 10% of your time taking care of the patient.
I bet that's pretty useful, though. I mean, like you take a certain rehab path with somebody and it ends up working. Now you've created a protocol for somebody else to follow, or the opposite. You try something that doesn't work and you've saved somebody else some time and going down that same road, maybe.
Both of those cases happen quite frequently as it happens. It's interesting because you can take two people, they have exactly the same diagnosis, exactly the same onset, and all that, and you can take them through the exact same rehab protocol or the exact same rehab program. They're going to respond completely different.
I would say even some of that's true in the work that I've done with you. We started out kind of headed down one road, and we kind of found out quickly that wasn't working for me, and you changed the plan.
Yeah, I mean, a lot of stuff plays into that, why people don't respond completely the same way every time. But yeah, in your case, I think you coming from more of an endurance and like high intensity interval training background, it kind of changed how we needed to train you, because your gas tank, so to speak, whenever it came to loading the upper body, is far beyond what most people I work with. So that had to factor into it. And so whenever you're developing a rehab program, and like you said with the documentation, some of it is discovery learning. Some of it is you try something and it doesn't work as much as you think it should. So then you start kind of tinkering with things and making some educated decisions along the way to kind of optimize it.
I think what you just said is really important there, because it's easy to get caught up in Googling around like, all right, what's the best thing to do for this? And then somebody thinks that's just what I'm supposed to do. But our friend E.C. Sinkowski is really good about bringing people back to, let's measure the outcome of what we do. And that's going to be the thing that tells us if it's working or not. We got to try it, see if it worked. And then that tells us if we're on the right track.
I might be demonized for saying this, because I know like it's an emotional crutch for a lot of people, but seeking information through the hive mind on community boards on Facebook is really not necessarily a good thing to go by, because you see it all the time. Somebody has shoulder pain, they go onto like the Starting Strength Facebook group, or they go onto whatever, and they say, hey, I'm having some shoulder pain whenever I overhead press. What do you think I should do for it? That's all the information that they gave about it. And you'll see 30 or 40 different responses. There's no uniformity among any of them. There's no analysis on any of them. You got about 20 of those people who have had shoulder pain before that will say, oh, it sounds like you've got a labral tear. It sounds like you've got a rotator cuff tear. And then you have the other people that just immediately say, go to the doctor. And then there's no actual good information on there. And whenever you crowdsource information like that, you're going to get crowdsourced information.
Right. Oh, man, that's so true. I mean, it's almost like the sign of a good coach is somebody whose first response to a question like that is another question. They know that they don't have enough information yet to even tell somebody what to do. There's about 5 more things you need to know before you even start to think of a plan.
Yeah, my shoulder hurts. If that was all it took whenever you went to an orthopedic surgeon's office, then an orthopedic surgeon could see 500 patients in a day. You could just wear a name tag that said shoulder pain, and they'd walk in and say, oh, okay, this is the surgery we're going to do for you. No, every single condition and your response to every single condition is going to have certain signs and symptoms. And there's a whole lot of information you have to get. But I think everybody wants immediate feedback. They want immediate feedback, and they want to associate with a like-minded community or share similar experiences. So you almost develop like these little communities of people who have had shoulder pain, people who have had knee pain, and they all kind of group together on these pages, which is that part of the community is fine, but seeking your information from there is probably not the best way to go.
And you get so much survivorship or survivor bias mixed into that too, because regardless of whether your injury is the same as somebody else's, like they know that's the thing that worked for them, so you should probably try it too, regardless.
Absolutely. Yeah, well, and then you also see a lot of like messianic complex type things like, well, I had neck surgery and I went to the best neurosurgeon in the United States, and it was this person. Like, how, by any metric, how do you measure that as being the best neurosurgeon? And that type of stuff. And I think like that, whenever it comes to rehab, that is actually probably one of the things that gets in the way of proper rehab for individuals in our community most, is because you have individuals that have experience, knowledge, and day-to-day work in that field, and then you have free immediate feedback by people who are on these boards all the time. Mm-hmm. And everybody just kind of, it's like the movement of the Tyrannosaurus Rex, like their eyes are just drawn to whatever gives them immediate feedback. So instead of soliciting information from a well-reputed source, that somebody who is known to have experience in that, people just go to whatever gets them an answer first, and then they start moving in that direction.
Yeah, it's true. And this is kind of like a symptom of the thumbnail soundbite culture that we live in. Like we just want that.
Absolutely. And I mean, for you as a coach, I mean, you probably deal with the same thing too, right? People maybe come onto your website or something, and they express some interest into what you provide, and without looking at all of the entirety of what you provide, maybe they just go online and say, what's the best high intensity interval training program to do, and then they just jump off that way. And
for sure. Well, like you just described a pretty busy day for yourself. When do you find time to train? Because you do a good job of documenting your own training in your Instagram feed. When do you train? Do you train like when you're not busy?
No, because if I trained whenever I wasn't busy, then I'd probably never train.
Exactly.
Most of the time, as long as I can manage my sleep and I can get to bed at a decent hour. So normally, if I can get to bed by about 10 o'clock, 10:30 at night, I'll get up at 4:15 in the morning and I'll train before I go to work. And so most of the time, that's when I train. I try to keep some of my heavier days for the weekend. So Saturday or Sunday are usually my really heavy days. Now, depending on sleep schedule, sometimes I can shift my workout to the afternoon whenever I get home from work. But that's usually a day that's an accessory lift and maybe like some supplemental exercises or something like that. But to keep myself on program, I really have to maintain that 4:45, 5 o'clock training session to make sure I get all of my core lifts in for the week.
I hope everybody heard what he just said. The only way for a lot of people to stay consistent enough to make progress and see results is to do it in the morning. And he said 4:15 in the morning, guys. Us that are waking up at 7 o'clock, 8 o'clock, we're like, I just don't have time. There's where the time is. It's before the sun comes up.
I'll tell you, I will be the first to admit, like, it sucks. There are days where I absolutely do not want to train. But you know what? I don't think that there's ever been a time that I've gotten up that early, even as much as it's been hard for me to get out of bed to go down to the basement to train, where I finished my training and I was disappointed that I did my training. Like, I'm always happy that I did it. And
that's the big takeaway right there. You got to have some forethought to know, all right, this is how I'm going to feel after I get down there and do it. I'm going to feel better than if I had not. You have a freakishly big bench press. I've always noticed that about you. I don't know how tall or how much you weigh, but I always have to like look at the numbers you write down for how much you benched, and I'm like, is that right? Is that even possible? How did you get to be such a big bencher, and where's your bench at now? And how can you help our listeners start to measure up to your size bench?
So Right now, so my heaviest bench press in the last two years or so, I hit 405 right before I left Washington. That was my all-time PR. My most current PR is 385. So I hit 385 about 2 weeks ago. And so I hit 385. It was pretty slow, but it was still, there was maybe a little bit of room in the tank. So I've dropped back down. I hit 365 this week. I'll hit 375 this upcoming week, go back up to 385. And then the next week I'll go 390, 395. And I'm 5'6". I weigh about 180 pounds on a normal day.
Have you always been just a strong bencher?
No. So whenever I was a freshman in high school and we maxed out on bench press for football, I failed at 25 pounds.
That's like less than the barbell.
Yeah. So I had to do a curl bar with 5 pounds on each side and I still failed on it. So no, I was not. Now I was a tiny human being as a kid. And so my bench press has gotten better as I've gained body weight, because whenever I was 135 pounds, I still have a training log from right before I went to Afghanistan. So I was stationed in Alaska at the time, and I wrote down all of my workouts and stuff like that. Now, granted, the type of training I was doing was kind of more aesthetic focused, or really it was just, there was no focus to the training. That's just what Muscle and Fitness told me I needed to do. Mm-hmm. If Jay Cutler did this to get ready for the Olympia, like why wouldn't it work for me? And so I wrote down all of my weights and stuff like that. I think at the time my 1 rep max was about 175 or 185. And I weighed maybe 135, 140 whenever I left for Afghanistan. Now, whenever I was in Afghanistan, there's really nothing to do. If you're not on mission, there's nothing to do but work, eat, and work out. There's very little time to sleep. And so, I mean, we were lifting twice a day, most days of the week. And you basically just lift until you got injured, and then you'd have to take some time. And I left Afghanistan with a 315 bench as a 1 rep max.
Wow. That's fantastic. What do you think your body weight was at that time?
I came back. So I left for Afghanistan at probably about 140, and I came back at about 165. I gained a lot of weight, but I had never eaten so much in my entire life. We had a 24-hour dining facility where I was stationed, and so you could go in at any time and eat. And out of boredom, you would consume more calories than you ever thought possible.
Did you know anything about nutrition at the time, or were you just eating calories?
Not the slightest. I had no idea about nutrition. All I knew is that I was just hungry all the time, and so
or bored.
Yeah, and then also about that time is whenever I found starting strength, and so it was towards the second half of the deployment whenever I'd found starting strength, and it was probably the last half of the deployment. Myself and the little nucleus of people I was working out with started doing the novice linear progression, or whatever bastardization we came up with that was kind of based on that, and that actually sent my lifts skyrocketing, because no time had I ever focused deliberately on strength. And so but at that time I had gained quite a bit of weight. And so, and I've got short arms, I've got short legs. So if I gain weight, like my leverage has changed very, very quickly. Yeah,
that was the first thing I thought of when you said that.
That made me a much better bencher, and it made me a much better squatter. So I'm actually a much better squatter than I am a bench presser. I'm a horrible deadlifter for exactly the same reason.
Yeah, you need those long arms for the deadlifts.
Yeah, my little Tyrannosaurus Rex arms. Like I'm not a good deadlifter.
Do you ever mess with sumo?
So I'm actually even worse at sumo, because to be mechanically advantaged for sumo, like you have to have even longer arms. And so for me, like I can't even get into position to sumo deadlift. And so, I mean, I've toyed around with it, but I actually can't even reach the bar.
It makes sense if you think about it.
Yeah, you've got to have long arms to be a good sumo deadlifter.
Yeah. You said you would train until you got injured. Let's get into kind of talking about some injury stuff here. Probably the most common thing we see with people back even when Blakely owned the gym, and even now, is are shoulder injuries and low back injuries. Is that kind of what you see in clinic too, as far as the most common things?
So the three most common injuries we see, number one is runner's knee pain. Number 2 is low back pain, and number 3 are shoulder injuries. So yeah, but we have a demographic that runs frequently, and so runner's knee pain becomes the number one thing that we see. What's interesting is if you go to a deployed environment, that completely changes. So shoulder injuries or shoulder pain becomes the number one thing that you see. Low back pain is number 2, and then knee pain goes way down the list because overseas, like, nobody really runs all that much, so you don't see a lot of runner's knee pain.
That's interesting. I think a lot of people don't think about the risk of injury with running. Such a low barrier to entry, just slap on your shoes and hit the pavement. But yeah, I mean, it's a lot of force going through your knee, and if you don't build up over time, man, I'm sure you see people go to running from nothing to several miles in a day, or 20 miles a week, and it doesn't take long for a chronic injury to creep up.
Yeah, I can't remember the exact study, but what they looked at was frequency and amount of time running. And basically the synopsis of that study was that people who run more than 3 times a week for more than 30 minutes at a time, or 90 minutes cumulatively throughout the week, have like a 93% chance of developing a run-related injury that keeps them out of running for more than 2 weeks. I mean, so you're almost approaching 100% of people who run 3 times a week for 30 minutes at a time or more. And I mean, that's really not hard to do.
Yeah. I bet, a month from now, we're putting this out mid-January. A lot of people probably started a workout program or just Googled how to get in shape on January 1st, and probably running 30 minutes a day, 3 times a week is at the top of a lot of people's list. So probably 2 weeks from now, 4 weeks from now, you're going to start seeing a lot more of that kind of stuff pop up.
Oh, I'm already seeing it in the clinic. And the weather has been kind of unseasonably warm here, so people are out running on the pavement a lot earlier than they normally do here. Most of the time, historically, at the place that I'm at, and with the population that we have, whenever it gets cold, everybody just goes home, jumps on their Peloton, and then they develop biking-related injuries. But now we're seeing more run-related stuff earlier in the year because it's been unseasonably warm.
What are some bike-related injuries that you see?
It's usually hip and groin pain, honestly. It's hip and groin pain, and then thoracic spine pain, because people who aren't used to being in a biking posture then kind of take up that hunched over posture. And it's just they have had no progressive exposure to that, and then they just jump on their Peloton for 60 minutes a day, every single day, trying to get in shape. And that's just too much load too soon.
Yep, that makes sense. Talk about I think most injuries can be categorized into 2 different categories: acute and chronic. Talk about the difference between both, and kind of the different approach, and how somebody would even know, do I have a chronic injury or is this an acute injury?
Yeah, so I mean, the best way to tell is, like, your acute injuries are typically something that the exact moment in time that it happens, that the exact step that you took that sprained that ankle or tore your ACL or something like that. Things that, you've kind of, we call it insidious onset. So things that kind of creep in over time. There's no definitive mechanism of injury, but like maybe your shoulder's been a little bit sore, it gets a little bit irritable after workouts, and that goes along. And then all of a sudden, maybe there's a more acute exacerbation of it, or it makes it worse. But instead of saying chronic injuries, I would say acute, and then there would be a loading related injury.
Mm-hmm.
Acute injuries there's too much load put on that tissue at one time. It causes an acute failure of the tissue. That's totally different than improper loading over time, because a lot of times those will be termed overuse injuries. But I know as a coach that you've seen it, and I see it in the clinic, that a lot of people who have what we historically term an overuse injury, they're not injured because they've overused that structure. More likely than not, it's a detraining related injury, that they've gone too long with no progressive stress on that tissue, and then they try to do something. So it's actually more a result of chronic detraining or chronic degradation of their stress response to that type of loading that causes the injury. It's not that they've done too much for too long. It's that they've done too little for too long. And then whenever it makes their body less capable of dealing with a stress impulse to that area. And so the way that you deal with them is honestly quite similar. You just have to make different decisions along the way. The first thing that you have to do is that you have to approach it analytically. You have to know what happened, what caused it to happen. If it's an acute injury, like maybe I shouldn't have gotten hit by the bus. That was what caused it. Maybe I should have looked both ways before I crossed the road. But then having some information about what structure is injured, and then going through a methodical approach of what am I going to do for that. In an acute injury, a lot of times you're going to have catastrophic failure of tissue, whether it be bone, ligament, tendon, something like that. And then the first thing that really should happen is determining, is this something that requires medical intervention or not? And that's probably beyond the scope of just this talk right here. But once you've done that, if you're not able to load that particular structure or that limb or whatever, you really have to just go through and decide, what can I do? What modifications can I make to my normal program to allow me to load everything else as good as possible, so that I'm still continuing to train, even though, like, my left knee, I can't squat on it. So what else can I do? And then whenever you do that, you can also take advantage of the crossover effect, where if I load my right leg, it's going to cause physiologic changes in my left leg. So even if I'm completely unable to load that left leg, by loading that right leg as heavy as I can prevent a lot of the muscle loss and atrophy that comes from not being able to load that limb. Now, in a chronic or an overuse or a detraining related injury, it's all programming. And so that's where it's probably easier, honestly, to rehab an acute injury than it is an overuse chronic or detraining injury. In that case, you probably should have somebody, because obviously at that point, you are not managing your load effectively. And I'm not saying this to try to drum up business for either one of us, but just if you look at it analytically, you have not been able to manage your stress appropriately. And it's probably because we are all emotionally invested in our own training. At least most of us should be, right? And so it's very hard to take a look at our own training and pick out what's wrong with our training. It's much easier for somebody who is not emotionally invested in our training to take a look at it and be able to point out, this is where the problem is. You're doing too much. You're not leveling the stress out throughout the week or something like that. For chronic type stuff or under overuse injuries, detraining injuries, those are the cases that really need to have an educated person start to program for them, or at least take a look at their program and show them where the problems are.
Yeah. It's almost like I like the way you phrase it about it's a detraining injury, really. So when you've taken some time off, or you have a new stimulus to yourself, you jump into this new thing, you kind of outpace your body's ability to recover from what you're doing. Mm-hmm. Everything we talk about with getting stronger, building capacity, is really just taking advantage of the stress recovery adaptation cycle. So you've thrown something off balance in that whole cycle.
Well, the whole time that you haven't been forcing your body to just progressively adapt to this, the body goes through stress recovery adaptation, both positively and negatively, right? Like, look at a professional bodybuilder once they've retired from professional bodybuilding. What happens to their physique almost immediately? They start to lose a ton of weight, because their body doesn't need, for the stresses that they're putting on it, their body doesn't need 130 pounds of extra muscles. So the body starts stripping that away. The same thing happens. Most of our body tissues adapts to regular stress. But whenever you're not putting regular stress on it, the body adapts to that as well, because we don't need increased muscle mass. We don't need increased tendon thickness. We don't need increased bone density if we're not doing that stuff. So the body wants to bring us down to essentially the lowest metabolic state necessary to maintain homeostasis. So all of that tissue is actually degraded over time, which is why we see people who live a mostly sedentary life have far greater risks of osteoarthritis and things like that than even high-end athletes. Mm-hmm. The degradation of tissue happens. So then whenever you've gone this long period of time and you haven't positively adapted to stress, you've actually negatively adapted to the lack of stress. So then if you look at how much stress does it take to send your body into an alarm phase because of the amount of stress that's put on it. If I've been training for a long time, the amount of stress it takes is a huge amount, right? Yeah. Typically for overuse injuries, it's a whole lot of stress that's given multiple sessions per week, or it's a very frequent stress over time. For someone who hasn't been doing anything, it doesn't take a whole lot of stress at all. So you take someone who hasn't run in 15 years and then they just decide to do a couch to 5K program that they line, but they want to make up for lost time. So they go out and they run 30 minutes. By the second or third time that they've run, they've already developed an overuse injury, which is not really because they've done too much. It's because they've done too little for too long. And their body's just not robust enough to take that amount of stress.
That's a great point. I remember you brought that up when we first started working together, because like my issue was pressing overhead. So we still need to stress that connective tissue as much as we can in a way that doesn't increase pain. So we found movement patterns that work, that don't increase pain. And we're doing things as similar as we can to the overhead pressing. And what you just described is really the reason that the whole take it easy approach doesn't work.
Yes, no, take it easy does not work. And we have, and it's one of the unfortunate things about the medical community. So the medical community is based off of what we term evidence-based practice. Evidence-based practice. So in evidence-based practice, there's three pillars of information that guides clinical decisions. There's the best available evidence. So what does the research, what does the literature say about this particular condition, treatments, and stuff like that, risks of treatments? What is the patient's values? And then what is the clinician experience or clinician education or their intuition or whatever? And all of your clinical decisions are supposed to be equal parts of all of that. But what you find whenever it comes to musculoskeletal injuries, very few clinicians can manage musculoskeletal injuries appropriately. And the reason why is because most of them don't have the time to either know how to do it effectively, because a primary care manager, whether it be a nurse practitioner, a PA, a family medicine doc, or whatever, they have this huge breadth of knowledge that they have to have. They have to know how to be able to recognize and treat STDs, common colds, upper respiratory infections, how to be able to pick out whenever this back pain is cancer and stuff like that. So they've got this huge breadth of knowledge. We cannot expect them to be experts in how to treat ankle sprains. Then it comes down to clinician experience and patient values. The clinician experience is usually they don't see continuity of care. Most musculoskeletal conditions will resolve themselves within about 6 weeks to about 3 months. So somebody comes in, it's not anything that's life-threatening. It's not anything that requires additional investigation. So you know what? Just take it easy for 6 weeks. And if it's not better, then come back and see me. But also, they cannot stress enough how much patient values go into even evidence-based care. If a patient comes in and is essentially demanding pain relievers or something like that, they're a lot of times going to get that because our healthcare system is based off of things like patient satisfaction scores and things like that. And so the family practice doctors and primary care managers have to balance all these things, and the evidence is something that they're not going to be able to stay up to date with all the time. And if they do, like, great on them. But that's why we have referral sources. You can send them to physical therapy, you can send them to orthopedics and stuff like that, because now our scope is much more narrow. And so we can actually be specialty consultative experts in that field. But we have this growing body of evidence that becomes even more conclusive every single year that essentially no matter what it is, whether it be back pain, the worst thing you can do for back pain is bed rest. And we have several studies that show that bed rest for back pain is the worst thing that you can really do, other than advanced imaging without a key indication for doing it. But bed rest for back pain was the standard treatment for probably about 40 years. Yeah. Whenever people had severe back pain, they were told to just put on bed rest. Ankle sprains almost sounds like it would be useful to give somebody 6 weeks and just let things heal, but the outcomes are far worse. So where we used to have this term or this acronym called RICE, rest, ice, compression, elevation, and that was the standard for musculoskeletal treatment. That is not the case anymore. Now you could essentially get rid of RICE and you could change it to PCE, and that's protection, compression, and early loading of tissue. And so PCE actually leads to far better outcomes. Now, the compression for that is compression tends to make things feel better. So if you have an ankle sprain, if you have, a sore bicep or a sore hamstring or something like that, you can put compression on the area, and that actually allows them to train at a slightly higher level, which will usually make their outcomes much better. So ice is completely useless for the most part. Rest is completely useless for the most part. And elevation is really not even something that you should factor into that, because it's something that we do anyways, but it's not part of the recovery process. It's symptomatic management.
Yeah. Man, you just made me think about 300 things that I want to talk about, but I'm never going to remember them all. But you
can chat anytime you want to.
You glossed over something that I think was really important and interesting, and it probably flies in the face of a lot of what people think. I think what I heard you say was one of the worst things that you can do is go get an image of an injury. And you had a disclaimer on there, but talk more about whether we should or should not jump to going to get an MRI on something when we feel something wrong.
Okay, so this is again, like you're probably going to see people demonize this thought process, but where some of this comes from is whenever you look at longitudinal studies on back pain, one of the key prognostic factors for somebody developing chronic persistent back pain is having imaging. The other thing is that what's the number one prognostic indicator on whether somebody's going to have surgery on their back? Well, number one is, did they get an MRI? Number two is actually what zip code do they live in? So if you live in the Seattle area, that's the highest density of orthospine surgeons and neurosurgeons in the country. And so guess what? You've got a lot of orthospine surgeons. You've got a lot of neurosurgeons in that area. You'll find somebody that will do surgery on you. But then if you look at the success rate of back surgeries for something other than trauma or progressive neurologic deficit or something like that, if you just look at back surgeries for pain alleviation, they're really not that successful. But here's what happens. So the vast majority of injuries do not need an image to diagnose it. They need a competent physical exam, and they need a good subjective history by the patient. The patient can tell you what's going on with them nearly 100% of the time, and then your physical exam either supports or goes against what they're telling you. So if somebody tells me like that they have, let's say that they feel pain that's going down into their biceps, and they've been doing a lot of this particular exercise, and it sounds very much like this is probably proximal biceps tendonitis. And everything in the history kind of matches that. But there's a couple of other things on the list. Whenever I start doing the physical exam and I do speeds test, or I do any of these orthopedic exams testing the biceps, and I'm not getting anything on that, but I'm seeing that the supraspinatus is weak on an empty can test or something like that, or that they're a little bit weak in abduction from neutral. Well, one of the referral patterns for supraspinatus pain is across the bicep. So even though they're saying it's coming down the bicep, it's probably more likely that it's just that referral pattern down at the bottom of the biceps from the supraspinatus. So that's where a competent physical exam can differentiate between this and this. Now, an MRI is not going to give you any additional information that is useful in that case. We know that it's not a surgical case because the physical exam shows that there's no overt mechanical dysfunction. There's no progressive issue that requires surgical intervention. But whenever you give an image, especially an advanced image, It's going to show you all of the anatomical deviations in that area. Now, a lot of times, the physical exam could say that the supraspinatus is what's the pain generator. But then you have an image, and it shows that you have a small labral tear. And so now the PCM who hasn't done the physical exam or a good thorough physical exam will now tell the patient, well, you have a labral tear. I'm going to send you to ortho. But you didn't do a physical exam to confirm that it was a labral tear that was causing that. So now you've now like made the suspect this labral tear that is actually just a clinical incidental finding. It has nothing to do with the actual thing. So, and you've probably seen it 100 times. I know I see it all the time that people had a surgical procedure. They come to me for rehab, and the primary symptoms that led them to have surgery are no better. They're exactly the same. So they've gone through the surgical procedure and now having to go through a rehab process for that surgery, and they still have exactly the same symptoms that they had.
And they've opened the door for future surgeries on that area.
Yeah, and it's hard for a lot of people to understand, because as a patient, and remember, patient values is a big part of medicine. It's a big part of medicine. If you are a patient and you feel that the only way that you are going to be treated appropriately is that you have to have diagnostic imaging, you're likely going to get diagnostic imaging, and it's going to it's going to change your potential for a good outcome.
Yep.
They show that the repeated use of advanced imaging leads to worse clinical outcomes. And
I'm always recommending people to hold off as long as possible on getting any kind of imaging. It's like getting your testosterone checked because you feel a little tired one day.
Yeah, the whole testosterone thing is really kind of it factors into this much the same, right? That becomes the thing that people who obviously do not train hard, they do not train regularly, they don't have their diet in check, their sleep's a mess, but they want to blame it on something that is not their fault. It's not their responsibility. And then they go and they have and you see it on the boards all the time, somebody goes and gets their testosterone checked and it's 650, and they're like, well, what do you think about getting on testosterone replacement therapy? You're like, there's no clinical indication for it. There's none whatsoever. Like, maybe you should make some other life choices that will benefit your situation. But the reason why you're struggling on your workouts is probably because of all these life choices,
right? And
not the fact that you have low testosterone, because you don't.
I prescribe you more sleep, squats, deadlifts, and more protein in your diet. Let's come back in 6 months and see how you feel.
And, and for the amount that a lot of these places charge for these, these male medical clinics and stuff like that specialize in testosterone replacement therapy, like, you could probably get a coach and do that for 3 to 6 months and see what that does for you. And then if that's not working for you, then maybe you can escalate care. But I mean, that's like the reason why advanced imaging sometimes and a lot of times leads to worse outcomes is because it escalates care unnecessarily. That whenever you do it, you order an image, and in our system that as a physical therapist, I'm allowed to diagnose, I'm allowed to make specialty referrals, I can order imaging and stuff like that. So I'm not speaking as someone who has no idea how to do this. Like, I do order imaging, I do refer to specialty providers and stuff like that. But what happens is whenever you order an image, you order a lab test or anything that is abnormal that comes back on those diagnostic tests, you as the clinician, you own that. And you have to make a decision based off of that. And the easiest, the safest thing for you to do as a provider, if you see a labral tear on an MRI report and you're a primary care manager, you do not manage that. You're going to send that to a provider who it's their job to manage it. So you get this referral, the increase in referrals out to specialty providers. Now you go to a specialty provider like a physical therapist. The labral tear may not have anything to do with your pain, but that's what you referred to me for. So I'm going to give you 3 times a week for 12 weeks because I've got to keep my doors open too. Yeah. And I'm going to give you treatment for your labral tear. If that makes your symptoms better, great. If it doesn't, it's not my fault. I was treating a labral tear.
That's fascinating stuff.
Yeah, but then that's where, I'm always always a proponent to patients being advocates for themselves, but being advocates for themselves to get the best treatment available, not just the terminal treatment, not rushing doctors to send them to surgery or for advanced imaging. And then you also have to be someone who has to be a conscientious consumer of healthcare, like being someone who can meet with your primary care doctor who's assigned to you through your HMO or whatever, and realize that that's not the doctor for you. So you as an active individual, me as an active individual, if I go to my PCM and I say, like I've started having some hip pain whenever I squat, and he says, whoa, you shouldn't be squatting. Like, you just do body weight squats. That's not the provider for me. I need to ask for a new provider, and I need to actually not doctor shop to get the treatment that I want, but I need to shop around and find a provider that is going to meet me where I am and make their clinical decisions based off of evidence-based practice, but also taking into account my values.
Yeah.
So it's just, what does the research say and what does your experience say, but what are my values?
Yeah.
Me being able to lift weights and live an active lifestyle is very much a core part of who I am. That physician, that physical therapist, that orthopedic surgeon needs to know that, understand it, and respect it, and allow the other two pillars of evidence-based practice to factor into that as well.
I think that's one of the benefits of some of this healthcare, at least the primary care stuff moving online, is you get to kind of look through your primary care doctors and choose somebody who does seem to have an alignment with your values too. There's limitations to that for sure, but that's one of the advantages. I want to start to wrap up, but a lot of the things that we've been talking about in the last 15 minutes or so come down to people choosing to have an active role in their treatment, their rehab, and having a more passive role. The person who thinks that I just need to get an image, that's a passive thing that somebody does to you. Somebody who thinks that I just need to get more massages or foam roll more, that's a passive thing you're doing.
Or like dry needling. Like,
right.
If you're the person who you want somebody to do something for you, for most musculoskeletal injuries, that is less effective than an activity-based approach.
So what kind of success rates do you see in people who come in with the mindset that there's something I actively need to do for and to myself to get better, and somebody who thinks like there's something somebody needs to do to me to make me feel better?
There's probably just a handful of people that came in with that mindset over the last 9 years of clinical practice, that came in with that mindset that actually didn't get better as much as I thought they were going to get better. And I've dealt with childhood amputees. I've dealt with polytraumas. I've dealt with this incredible array of musculoskeletal conditions, from your minor ankle sprain to someone who got shot 5 times with an AK-47, like in childhood cancer, amputation of their leg. Like, I've dealt with everything, IED, like polytraumas. But the people who have that type of mindset, there's maybe a handful of them in the last 9 years of clinical practice that didn't get better the way that I thought or that they thought they were going to, and they required some additional treatment that was outside of what I could do, but they still got better. They still got better, just maybe not as much as I had hoped that they would. The individuals that come in that just want passive treatment, the literature is pretty much in keeping with what I think I see in the clinic, that only about 1/4 to 40% of those people actually ever get any better, get any market improvement.
Which speaks to just how important mindset is in this whole thing too. I'm not even talking about like the psychological effects on actual pain, but just in recovering from something, like, you have to, Darren Deaton always says, you cannot adopt an injured mindset. And somebody who has an injured mindset is somebody who's looking for passive treatment all the time.
Yes. And that was one of the hardest things to learn as a student, as an intern, and then as a new physical therapist was, you're looking at your batting average with patients that came in, and you'd see these patients for, you'd see them, they'd come into the clinic for treatment, follow up, no better, bring them into the clinic again, treatment, no improvement. And you'd see these people for 3, 4, 5, 6 months, and they didn't get any better. And you start realizing that your batting average is actually really not that good. that people just aren't getting any better. Of course, you've got all these people that do get better and they've got the same diagnosis, but what is it about these people that aren't getting better? And then as you spend more and more years in the clinic, you start to be able to discern that mindset, self-efficacy, the belief that they can get better, the desire to actually get better. You start seeing yellow flag behaviors that people maybe with this particular condition are getting a benefit from that condition that prevents them from wanting to get better. So, there used to be this whole list of things in the DSM-3 that was like compensation neurosis, whiplash neurosis, stuff like that. But basically what it was is like, you look at people like in a workman's compensation setting, that people can have a certain diagnosis, and as long as they're getting workman's compensation for it, their outcomes are really poor. If somebody's been in a motor vehicle collision and they're pending litigation, their outcomes are poor pending the litigation. Once litigation is over, their outcomes actually become better. And it's not necessarily that people are faking these. They're not faking it. It's actually organic pain, but the mindset is different there. If you're somebody that has a motor vehicle accident, same speed, same type of collision, everything like that, but they actually cannot miss work because they don't have workman's compensation, they don't have insurance, they don't have pending litigation, they have to go back to work. They actually get better much faster. And that with the research with whiplash associated disorder, the number one prognostic indicator for somebody with a diagnosis of whiplash on whether they get back to normal function is how fast they go back to work.
Yeah. So it kind of like feeds on itself, like shows you, okay, I can work. I should feel better. I do feel better. And it's this cycle.
Yeah. It's really fascinating, but it's also quite frankly, it's really disheartening, because what happens as a clinician, what happens as a coach is whenever you're working with somebody and like you cannot impart that feeling of self-efficacy and stuff on people. And so you have clients, you have patients that come in that the only thing they really need is they need to believe that they can get better, and they have to allow themselves to get better. And you see time and time again that a lot of people's mindset, they do not want to change their mindset. They identify with their condition, they identify with their disability, and even though they'll vocalize that they just want to get better, they just want to be able to run again, whenever you really get down to it, they don't, because they don't want to put in the work that will allow them to do that.
There's a difference between wanting the outcome and wanting to do the things that lead to the outcome.
Yes, exactly. And I mean, it's really sad. And like, this is one of the things that like, I don't think people realize about like clinical care and clinicians. Like, a lot of people think that clinicians just don't give a crap about their patients, that we're just there to get a paycheck and we don't really care if they get better. We're just there as kind of this like sausage grinder of just getting people in, churning them through the system and stuff like that. But I don't know a single provider that I've worked with that does not go home and toil about certain patients all the time. Like, this is a weekly thing that you have that one patient that week that you just know, oh my God, if I could just get to understand this. And like, I mean, that's why things like alcoholism and stuff like that is like so big in healthcare fields. It's not because the stress of the job sucks, and like a lot of medical providers are stressed a lot, but there's so much in the field that like you see the ill effects of certain patient behaviors, and you know that this person could get better, but then you kind of see this descent into darkness with some of these patients, that they come in, they're doing okay, but another provider gives them a diagnosis with no education on it. They tell them they have degenerative disc disease, and now all of a sudden that person starts walking different, and then they start acting more disabled, and you know that they're functionally capable of doing more, but there's no incentive for them to get better, or no incentive that they see or that they think is accessible to them. And you see this all play out in real time. And this is a really, really hard thing to deal with, especially if you actually care about, your patients.
Yeah.
And
we've talked about it several times on this podcast that, I mean, there are literally nights that I lose sleep thinking about a client that I really want to get the outcome that they want. Like, what else can I do? And like, a lot of it just comes down to accepting the fact that I can motivate, I can coach, I can provide resources, I can provide the plan, but at the end of the day, your patient, my client, they have to be the one to lift the weights. They have to be the one to put the food in their mouth, and it's hard. That's just part of being a coach.
The community is also not entirely helpful either. I did an interview, or maybe it was a lecture, with Starting Strength, and one thing, it's very memorable to me. So in this talk that I was given, I was talking about, in the physical therapy world, that if you own a civilian clinic, you have to have patients in your clinic all the time to keep the doors open. The reimbursement rates are very, very low for physical therapy. So if somebody has been told by their doctor that they're going to authorize 12, or let's say 36 visits 3 times a week for 12 weeks for this, by God, you're going to put that person in the clinic 3 times a week for 12 weeks, and you're going to get your 36 appointments. Now, does that mean that person's going to improve markedly over that entire time, or that it really takes 36 appointments for them to get better? No, but from the business standpoint, you're not doing any harm by bringing them in 36 times, but that's what's going to pay your bills, and you need all of those, right? But in my system, I have a never-ending supply of patients coming through my door, and I don't have to worry about funding for my clinic. My clinic is funded by the United States government. So the statement that I made was, I don't have to keep patients in my clinic for a long period of time. Like, there's no incentive for me. I don't get paid extra money or anything like that for bringing somebody in for 12 weeks. And there was one particular comment where somebody called out my lack of ethics, because I said that I should keep this patient as long as it takes to make sure that they're healed. And it was like, wait a second. Number one, you totally misunderstood what I said. And number two, like, there's no ethical
motivation.
There's no ethical dilemma here that I have to hold on to every single patient until they're perfectly healed, because it's part of clinical care, is that I have to be able to determine when somebody has the potential to get better or not. But it's like that. But that's what permeates online discussion boards and online communities. If you want to know, if you want to see that the human condition is inherently flawed, and that people are not inherently good people, just go on to any comment section of any news story, any YouTube video, any Instagram post,
Reddit.
Yeah, and you just go in there and you just see just how bad people can be for no reason at all.
It's amazing what some anonymity will do for people.
Oh, absolutely. Or just drive on an interstate in California. You'll see that people don't. There's no sense of community. Nobody's looking out for their fellow man. They're just in it for themselves, you know.
Way to bring it down to a downer at the end of the interview, Will. Come on, man. Humankind.
No, it's just funny. But then but the reason why I said that is because that's what a lot of people will go to, that same community, to seek their information, and
that's
then you
true.
wonder. And then you wonder why people are then looking for a PCM that will just do an image, that will send them to a surgeon, because they're getting information from the worst people you should get information from, because they're actually just...
It's like you said earlier, it's the hive mind.
I want to know, like, who spends that much time on the internet commenting on news stories, or commenting on Instagram posts, or YouTube videos and stuff like that, because I definitely don't have the time to do that. I know you don't have the time.
I have no clue where the people find the time to do this kind of stuff, or take a quiz on Facebook to see what kind of artichoke they are, or something like that.
Yeah, I don't have that time. I don't. But what I do have time for is, I do have time for people to contact me, ask me questions, ask for my feedback and stuff like that. You produce a lot of content that's actually really, really good. In the fitness world, your content, and yours and Blakely's content, is some of the best that's around.
We're trying, man. We're trying.
It's positive. It's useful. It's actionable intelligence. It's really, really, really good content. And people could spend their time consuming content from that, or you could just go to a Facebook group page and ask a question, and then just deal with the same amount of time listening to 30 or having 30 people respond that are all giving you different answers, none of which is helpful at all.
It's true, man. Well, tell everybody how they can find you on the socials, or what the best way to reach you is. And I will mention that Blakely and I are talking with Will about a more formal way for you to work with Will through Digital Barbell that will be available to our clients too, who are trying to work through injury. But in the meantime, tell everybody how they can find you.
Yeah. So the way that most people find me is through Instagram. And people like have seen my name or heard my name or seen a lecture or podcast or whatever. And so I'm on Instagram. I think that my like little name on Instagram or whatever is just Morris DPT SSC.
That sounds right.
But then again, like I'm not big on social media, so like I think that's what it is. And then people also email me, and my email is william.morris217@gmail.com. At some point, I'm probably going to make all that stuff like more professional. But at this point, like my coaching and stuff like that it's a second career. It's a hobby of mine. So I haven't put as much into formalizing it into a professional.
I'll link to all those in the description of this podcast so people don't have to memorize that. But yeah, I really appreciate your time. It's been great working with you so far. I'm enjoying the gains that I've been making, and my shoulder feels better because of you. So I'm thankful for that too. You're a breadth of knowledge.
Yeah, and you hit a PR deadlift, and we're not even really focusing on the deadlift. Somehow you just stumbled across a PR in your deadlift, and you did
consistency, baby. Well, thanks again for your time, man. If anybody has any questions about Will and you just want to reach out to him, go for it. If you need any help from us, you know how to reach Blakely and I at all times, and we will definitely catch you guys next episode.